Good morning.
Nice to meet you.
Hi, how are you? Hi, John Canelopoulos. Nice to see you.
Nice to
Hi,
meet
how are you?
Mira.
Welcome. I hear you come from a long way.
Yes.
Wow.
You were highly recommended.
Oh, that's quite flattering for us.
Yes. Dr. DeRose.
Okay. All right.
He said.
And you're coming in from where?
Pennsylvania.
Okay. A nice part of the U.S.
Mm-hmm. Yes.
So yeah, I read the correspondence and I've seen the combs. We're 24, if I'm not mistaken, right, John?
23.
23. And diagnosis was 2 years ago with...
Yeah, I think actually 2012. So
2012, about 3 years. With mild keratoconus on the left eye. Anybody else in the family that has keratoconus?
Not that we know of, and his father passed away, so we
Okay.
couldn't even get him tested.
Yeah, sorry to hear that. But we'll check mom. And see if she has the gene. We can tell from the pictures whether somebody has a slight flavor of it.
Okay.
For somebody who's over 40, it doesn't really matter clinically. It won't affect them for the rest of their lives.
Right.
But for somebody, that would help you guide which part of the family has to be evaluated for keratoconus.
Okay.
So, for instance, if we see a little suspicion in your corneas, that means that any nephew or niece that you have that are in puberty, so 15 to 18 years old, they should be checked for keratoconus
Okay.
preemptively. I mean, these statistics, of course, are based on our Greek experience, because in Greece, keratoconus is rampant. Almost 1 out of every 25 Greeks has a sign of keratoconus, just like John.
Really?
It's quite rare in other countries.
And what is it for other nationalities?
In the U.S., older statistics showed 1 in 2,000, so it's a huge difference.
Wow.
But that was at the time that we didn't have tests that were so sensitive.
Right.
So I assume if somebody ran a test now, it would probably be a little bit more common, but nowhere near 1 out of 20.
Right.
I'd say probably 1 out of 500, 1 out of 600.
That's amazing.
Yeah, it is amazing. So we're looking at the eyes here. Of course, I'm seeing keratoconus on the right eye, not the left eye. And I'm not sure this is keratoconus, honestly. There's a little bit of a cornea irregularity. The cornea is steeper superiorly. The left eye, which we always like to study carefully, the eye that quote-unquote is not affected, looks perfectly normal, has very regular astigmatism, and the thickness maps, the thickness transcends from central to periphery very smoothly. That's another sign whether the eye is 100% normal. So we look at the power of the cornea, as if the cornea is a lens. We're able to photograph it and see if the lens power of the cornea is symmetric, if it's even. So if we cut the cornea in half, the top half looks exactly like the bottom half. So that's symmetry. Asymmetry in keratoconus is, for instance, this, the right eye, where if you split the cornea here, this part is not symmetric to this part. The interesting thing is that the steeper part is superiorly, which is unusual for keratoconus. Was John a normal delivery?
Yes.
You remember if forceps were used?
No forceps.
No forceps, for sure.
For sure.
Okay, that's important too, because sometimes forceps injury during normal delivery can create something that looks like keratoconus.
Yeah, no forceps.
I used to rub my eyes when I was younger because
Right.
of allergies. I was told that could be.
That is probably the most common thing. And the thickness on the left eye. Yeah, so we have mild keratoconus, the left eye only. The right eye only, I'm sorry. Left eye looks fairly normal. How are you functioning?
I can see it's not. My right eye is not correctable to 20/20,
Okay.
but the left eye is. So with contacts or glasses, I mean, I can function normally.
You function
drive,
very well?
Everything. Yeah.
How's night driving?
Night driving, it's not 100%, I wouldn't say, but it's fine, I think.
Right. Any ghosting of lights with your right eye? You see lights having tails,
Slight.
slight tails at night. All right, let me take a quick look in my hands here. I've got a little girl here, so this is a little too high for you. How was your trip?
Oh,
Good?
Yeah, I love Athens.
Yeah, it's a nice. This is not a good time
I know. It's a
to
shame,
visit Greece, but
but the food here is amazing.
Oh God, yes, it's beautiful.
George, want me to take these off?
yeah, please. It is a nice time of the year if you like swimming. There's a lot of beaches very nearby. All right, so we're taping this for John, and we're looking at the surface of the eye, and it's very difficult, even with these microscopes that magnify the eye, to pick up keratoconus by this, which is the traditional eye exam. One can look at it and say it looks normal. It's only the maps that actually give us the insight of what is actually going on. So we do have mild keratoconus in the right eye. It's probably from the eye rubbing, and the question is whether he's going to decide to freeze it. At this age, if he was Greek, where we have most of our experience, we would strongly recommend he freezes the cone, because this time of his life is very hot for keratoconus advancing. If he was 35, would be a little bit more stoic about it. The inside of the eye looks fine. If he was 45, we'd probably say it's not going to change. It's very unusual to change. If he was 15, even more aggressive. Of course, we want you to not rub the eyes.
No, I haven't did it since I found out.
That's great. That's good. When
I
they
don't
get it,
even take a shower. I don't let the water go in my eyes. I don't.
I want to see how loose the eyelid is. It's not. So you don't have floppy eyelids. Not at all. Very tight. Usually, people who are keratoconic and rub their eyes a lot have very loose eyelids, so you can pull the eyelid all the way up to the eyebrow. There's many options. One option is you can wait and see if this changes. Having a cornea, let me actually make a step back. In our protocol, we evaluate keratoconus based on three things. One thing is age. We talked a little bit about that. The other thing is how well you're functioning currently. And the third thing is how thick the cornea is, because that gives us the safety measure of even if things change, if we have room to work later. As far as the age, we're on the minus side, because you're young. It's good that you're young, but for keratoconus it's not good. As far as the visual function, you're functioning relatively well, and that's a good thing. As far as the thickness, the cornea is quite thick as well.
So what do you suggest?
If you want to improve it a little bit and also freeze its possible progression, you can have the easy cross-linking, which is epithelium on. We just put drops on the eye for 12 minutes, and then a special light. This is not available yet in the US. It is a light that has a pattern. So it is not just a beam of light like a flashlight that we use usually to cross-link the cornea. So we design these patterns according to your keratoconus, and we're able not only to stabilize the cornea, but to normalize it a little bit as well. And that's called trans-epithelial customized cross-linking. It's very easy as a procedure. Worst case scenario, the day of the procedure, you feel as if your eye has a little bit of sand in it. That's it. Next to your functioning normal.
Great.
So it has really zero downtime for you.
And what is the improvement in vision?
We expect the vision to improve some, not dramatically. Maybe a dot of astigmatism. The traditional technique that we do for people who have a little bit more difficulty in functioning, and where we're very much concerned about it progressing, meaning the thickness has come down quite a bit, is the Athens protocol, where we do the cross-linking, but on top we use a laser to reshape the cornea. This, of course, has far more dramatic normalization effect on the cornea. The cornea will probably look normal afterwards on imaging. That means the quality of vision is better. That's why we talked a little bit about quality of vision.
That's what you need, excuse me. Only because he always says, I can't see it. Does.
Yeah.
I mean, he really does.
Because it's not correctable, so I think it's, what's it, 20, 40?
Yeah, at best you get to 20/40.
Yeah,
So we expect your best corrected to improve a lot. The disadvantage, because I like to always say the good things and the bad things, is that the Athens protocol has a much longer healing time. There's a burning sensation the night of the procedure, and then it takes about 3-4 days for things to smoothen out, and it'll take 2 to 3 months to reach the level that we want it to reach. So it has a very long way to go, but on the other hand, it's a one-shot deal. I mean, it's very unlikely that you will need anything afterwards. The only thing that you may need afterwards is, for instance, a very simple prescription for myopia, maybe -1.
Okay, so this would correct the vision without...
This will reduce significantly your astigmatism.
And I would still need to wear corrective lenses?
We always make an attempt to include that in the laser treatment, especially in someone who has very thick cornea like you do, 540 microns. But it is a little bit of a guessing game, because when you reshape the cornea, you're not absolutely certain how the prescription of that eye will change.
Right.
As a rule, we can realistically tell you that the astigmatism will be reduced significantly, and if anything, you may have an increase in your myopia, your nearsightedness.
Okay.
So right now, you're very little nearsighted, you may end up being a -1. The other eye, your left eye, is a -3.5, -1 astigmatism. So much less than your left eye. Even if you end up being a -1, that means that without your glasses, your right eye will be your better eye for distance. And with glasses, it should be at par with your left eye. And in my opinion, if you wait a few years and everything's stable and everything's solid, you could have a second laser for that -1 if ever wearing glasses becomes an issue. Because you can have laser in your right eye to correct the nearsightedness. Having keratoconus in your right eye, that leaves you only one option of which way you're going to have laser if you have laser in your left eye. Having laser in your left eye involves 3 different techniques today for somebody who has your prescription. Having keratoconus in your right eye makes it a little bit more cautionary to use the surface technique.
Okay.
So the easy version is much easier to handle, but it will not have the same normalization effect. It'll have some normalization effect, probably 20 to 30% of the reshaping.
What do you think? If this was your son, what would you say to do?
Can you be off work for a couple weeks?
Yeah, well, I'm on summer break for college. I have 1 year of college left.
If you can handle, 2-4 weeks max being off work, and I would strongly recommend you fix the cornea.
Yeah, that's what I think.
Yeah, that's what I
Because I
think
started
too.
school, I think, August 23rd or 24th.
And quite honestly, John, the reason is that in our experience, we have found out that even though it doesn't bother you a lot now, at some point, even if the cornea stays absolutely stable, this irregularity will become a burden in your night driving.
Yes, it is almost like starting now. Like it's like noticeable. Here's the thing,
Right.
It's not correctable to 20/20, the right eye. So if I can get it finished with now.
Yeah. So that is the absolute more radical
Yes.
treatment, and we can make in designing this and offer you the possibility to maximize the chance that you will not need glasses. But I want to go on record saying that we cannot guarantee that.
I understand, because I was told in the United States by Dr. DeRose, it's not case by case.
Yes.
It's very much.
We definitely put all our experience in, and we've done over 2,000 cases like this. We started this about 12 years ago, and now this is practiced everywhere in the world.
Really? Wow.
So if you read about
And it's
Dubai,
not FDA approved.
it's not FDA approved yet. The problem is with the FDA approval, nor is the cross-linking or the topography-guided treatment approved yet. Actually, the topography-guided treatment, has been approved since October of 13, but it has not been clinically released yet. The company is trying to train the doctors slowly, and I was in Canada late last year doing the initial batch of doctors.
Right, they do it in Canada, I heard. Right?
Yeah, in Canada they do this.
Toronto.
Everywhere in Canada. Toronto, Montreal, Vancouver.
Well, why are you going to have the opportunity
Well,
to get the
Get
best?
the best.
You should do
Well,
it with
the procedure is very simple. The whole deal takes about 15-20 minutes. There's really no pain in the procedure. There's a little bit of anxiety. Nobody likes having things done in their eyes, but there's really nothing very uncomfortable in the procedure. The night of the procedure, there'll be a little bit of stinging.
Okay.
It's not going to be a comfortable night. We'll give you whatever is possible to make you comfortable. We usually give a shot of a Tylenol-like medication, which is very good as a painkiller. So if you go for the first night, you're basically out of the woods.
You'll do it. I'll be a nurse.
And the next day, worst case scenario, you'll be a little bit light sensitive, so you'll have to wear sunglasses to go out. 3-4 days max, the surface will be healed. So then you can go back to showering normally, etc., etc. And you need to protect the eyes from the sun for at least 2 months.
Okay.
So for that, we recommend a cap, good sunglasses that hug the eye. We'll give you a sample pair here, but if you have a good pair of glasses that hug the eye, and we also give you high doses of vitamin C, which is also a UV light quencher, because it finds its way in your eye, and that way it neutralizes the UV light.
Perfect.
And I mean, I want to show you some pictures just to get an idea of a young fellow we did here from New York, young lawyer, and we did him a month ago, Sebastian, and it's quite, because all this verbally sounds very confusing. And the key thing that I want you to stick in your head is images, to understand how this will help.
And what about for the left eye? Do you recommend any action now?
I wouldn't do anything right now on the left eye.
Okay.
If you decide to reduce your nearsightedness, you could do that. So if you have laser,
So could PRK be done?
yeah, you could do PRK. If you did the PRK with us, we would, since your right eye is keratoconic, we would add a portion of prophylactic strengthening.
And this would correct the eye to 20. Okay, so can I do both at the same time? Oh, that would be great.
Do both, yeah. We want your hands to do it and your brain.
It's all done. It's all
Yeah.
done by the machine.
Yeah,
So
but you have it.
better. It's a beautiful office too.
Thank you.
Yes.
We're the biggest center in Europe,
Bless.
and 50% of our work is keratoconus, believe it or not. This is how.
Do you have a lot of foreigners coming
We have a lot of usually Americans and mostly doctors,
in?
believe it or not. Most of our patients are U.S. doctors that come in.
So that's good. That's a good sign.
But we saw people from India last week, very affluent Indians. Okay, here's the key element. These are emailed to me yesterday from New York office, and young Sebastian has more keratoconus than you do. He had cross-linking in the U.S. This is what I was talking about, quality of vision. He had cross-linking 2 years ago, but he had a lot of problems driving at night. So this is a keratoconic cornea that's stable, but still gives him problems with quality of vision. So he came here, we treated him with the Athens protocol about a month ago, and this is how the eye looks now. So see how it was and
Wow.
how it is now. And the difference is the more starkling. This is now, this is before, and this is the difference. So you can see it's as if we reshape the cornea, and this is done by the machine automatically.
Okay.
Your left eye is very simple. It's a simple
Wonderful.
procedure. So we'll finish our measurements. We'll have you speak to our coordinating nurse, and if you decide,
We're
Fix it.
definitely doing it.
All
Yes,
right.
definitely.
we'll fix it. It's no big deal.
And then
You won't like us for a night, and then you'll be fine.
he'll be fine.
Yeah, I
Yes.
figure just get it done with.
All right. We'll do it.
And then what? Today you could do it.
Yeah, of course.
Perfect.
It's very quick.
Well, we have everything in the center, and if you actually see the whole center in our lab, we're almost 30,000 square feet.
Wow.
So it's a very, very big facility.
Yeah, I was telling people, they were asking about the surgery. I said it's like 15 minutes. They couldn't believe it.
Yeah.
Yeah.
Yeah, it's quite fast.
Right, I took my book.
Okay, so we'll probably look around for another 10 minutes, make sure we have all the measurements, and we'll wait for your pupil to come down. So we'll have you go eat lunch, whatever, and once your pupil comes down, then we can go ahead, because the device uses your pupil as a guide to know where your eye is.
Okay.
So
What do I
that-
just lay down into?
we're gonna show you the laser room so you know exactly how it's set up before we go in there. It's a nice bed. You sit back in the bed. We'll close your left eye first. We'll cover with a little sticker, and then we'll open the right eye. We put a little gentle instrument. There's nothing sharp about it that holds your eyelids open, and that helps you not to blink while we do the procedure. The only thing you feel there is as if somebody's pushing your eyelid.
Okay.
So your eye has no sensation. And there'll be a lot of lights ahead of you. There'll be 4 white lights and a little green blinking light, and you try and stay on that light. The machine will automatically capture, and your mother will be able to watch all this from the bedside. And will capture the position of the eye and all the movements of the eye during the procedure. The laser parts, it will be in 2 sessions, and it's about 20 seconds each. So it'll be 20 seconds of buzzing, a lot of noise, you won't feel anything. Then another 20 seconds of buzzing, a lot of noise, you won't feel anything. And then we'll start putting riboflavin drops, and then you'll be looking at a white light for exactly 18 minutes.
Okay.
And that's the right eye. The left eye is much shorter. Left eye will be just the laser buzz for 20 seconds, and then we'll put riboflavin drops for 4 minutes, and then there'll be light only for 2 minutes.
Okay.
Much shorter.
And this is like the PRK.
This is the PRK, we call it PRK Extra.
Okay.
So it's PRK with a
Well,
reinforcement.
there's like the LASIK, but the PRK is better, I was told. Because the
Well,
LASIK cuts the...
LASIK is much more comfortable, but you know, we
PRK
want to be
is-
cautious because
Right.
LASIK does open the potential doors that
Exactly.
that eye will
I was
change.
told about that, so...
Where
you
PRK
do
is
the
safer.
best that are available.
So when you get back to school in August, you should be extremely sharp.
Great. I'll be
Yes,
ready
I'm
for
so
that.
excited.
All right? The only thing you have to remember is sun is not our friend for the next 2 months.
Yes.
Okay. So
Even if it's
just
cloudy,
glasses, hat.
Glasses, hat. If you do outdoors activity, try for them to be before
Yeah, I'll
noon.
try to cut back.
Try, or after 5. Try not to be in the peak of the UV light, because you're quite the same meridian with us.
Yeah.
So
Here
when
it's much hotter, it seems.
it's hotter, but the UV light is about the same.
Yes.
It's about the
So
same.
no after dark.
Yeah, okay.